in prosthetic and limb salvage care. And we heard from the world's experts this morning, and so you got an absolutely front door insight into what the state of the art is. That was very exciting. Thank you, gentlemen. Our second plenary session this morning is Dr. William Hendrick, who is the president of the University of Texas Health Science Center here in San Antonio. He's been doing that since 2009. I'm finding as I introduce people, there's an interesting thing. The more a person is an expert in his field and the more he has accomplished, the more it lends itself to a short bio. Because if you start reading off all the things that the people who have been speaking to us do, they would never get a chance to speak. Dr. Henrich is a product of Columbia University and Baylor, and has had so many different professorships and chairmanships and vice presidencies that I'm not even going to start. But he has graciously agreed to talk to us this morning about the transitions in the San Antonio area around the University of Texas Center as it relates to military medicine, VA medicine. So this is all a part of the fabric of what we have been trying to approach. We're very proud to have Dr. Henrich here.
Thank you very much, Admiral Cowan. Good morning, ladies and gentlemen. It's my privilege to be here. I started the idea about this talk with developing a hypothesis, the hypothesis being that you could test whether or not an academic medical center could truly be integrated with military medicine in the 21st century. And the punchline of the talk is the answer to that question is yes, it can. It takes a great deal of trust, it takes a great deal of experience to do this, but in San Antonio we have been blessed by the existence of these two institutions and been able to harness to some degree the positive power of this interaction. And I have a few slides to show you that bolster this point. So it's my privilege to be here. It is a privilege to be associated with this meeting. And in all ways, our Health Science Center is a wonderful beneficiary of this relationship with the military. So the rhetorical question is, can the military medical system work synergistically with the military partner? Has this been done before successfully, and does each party offer the other sufficient benefit? To start, there is obviously a great deal of overlap that might lead the naive person to say that it's easy to do this. Both organizations have significant clinical care missions, of course. Both organizations are devoted to education and have that embedded in their daily work. Both organizations have robust research enterprises, and both organizations have as their raison d'etre clinical service and service to the community. There are many similarities between the military medical profile and academic medical centers. One is that they're both hierarchical. There's a certain order of things in both organizations. Happily, both are mission-based. Always, both organizations face significant budget constraints. There's always sequestration or something to deal with, restrictions on travel, restrictions that are embedded in our daily lives. We are always mindful that we hold monies in public trust, and in carrying forth our missions have to make discriminating decisions every day about how we invest those dollars. We're characterized by a dedicated workforce which is highly focused on getting a job done. We're aspirational. We come to work every day dissatisfied with where we stand and dedicated to making ourselves more efficient, more prolific, more of service. Creativity is a large part of our work, and we are large organizations, and we're complicated. We're complicated by the fact that we're comprised of people, and that in organizations where there are aggregations of smart people, it is sometimes difficult to move forward because there's a volleying back and forth all the time of ideas. Now, there's some differences in us. There's a cultural difference between the military medical hierarchy and the academic hierarchy. The military can often be more directive in how it assigns projects and how it carries those projects forward. It is always to advantage in the military system to gain consensus. But in certain circumstances, there may be operational directives which become imperatives, and carrying out a mission may dictate certain steps be made. In the academic world, nothing is done by direct order. I say nothing, I guess there have been a few things that have been done that way, but in my life, in my 20 years of being a physician and combination with an administrator role, my observation is that you have to have consensus. It is why academic centers sometimes take longer to get to the goal line. And sometimes, in the case of some places, never get to the goal line, because consensus is impossible to reach. The genius of every forward step in an academic medical center, I believe this is true for the military, is execution. And so consensus is not a trivial point. It requires every erg of skill that you have to reach the desired effect. And it takes sometimes forever. When you have a meeting that you're facing next week that's on an important topic, it's the 20 meetings that you have before you get to that meeting that are the pivotal steps, because the meeting itself will just not be successful unless those steps are taken. So there are some differences in these cultures. There are different ways of doing things, different ways of procurement, different ways of getting to a goal. But in large part, as you can see from this slide, we have far more that unites us. Now, San Antonio has a rich history. Many of you in the room are aware of some of it. On the left-hand side of the slide is a picture of the old Fort Sam, which was formed in 1876. Camp Bullis was created in 1917 and still is very active today. Randolph Air Force Base, 1928, Lackland, 1941, Kelly and Brooks have distinguished histories here in San Antonio. The Health Science Center is relatively new. It was formed as a group of health science centers, and medical schools were created in the United States in the late 1960s and early 1970s. You may remember there was a whole spate of them that came online, about 20 of them in that era. There's now a recrudescence of that effort, as many new medical schools, several in this state, are being created to try and reach the goal of abating the physician shortage. Nevertheless, our school was chartered as a medical school in 1959. The governor signed the decree that allowed it to come into existence, and as often happens in politics, it took 10 years before it was created in physical reality. The reason for this was political. They couldn't decide where in San Antonio to site the medical school, and there was a raging battle between those who wanted it downtown and those who wanted it out, which was then far away from downtown, out in the northwest section of town. It was created ultimately in the northwestern part of the city It is not an inner city medical center. The Health Science Center has found that this relationship with the military has been, if you could say this, in the advantage of the Health Science Center from its very beginning. Fort Sam Houston and Brooke Army Medical Center were already renowned in Army medicine. They were already decorated medical centers. They were renowned for their burn program and their trauma care programs. Lackland Air Force Base had Wilford Hall as a part of it. Wilford Hall was a renowned, decorated Air Force facility that had national class, world-class physicians, research, and education associated with it. And it was this presence of military medicine that led to the phenomenal growth in the University of Texas Health Science Center. It not only led to its growth, but it led to its excellence at an early era, an early stage, because the founding faculty of the medical school and of the dental school, the nursing school, were from the military. And today, no fewer than 13% of our faculty are retired, distinguished military personnel. And believe me, I can say, as the former dean of the medical school and as a president, we are lucky to have them. I count my lucky stars that we have this association because they come to us as faculty already trained in clinical medicine. They're very good clinical care providers. They're excellent teachers. They're creative thinkers. And they understand hierarchy and team play. And that has led to a much smoother acquisition of consensus that would not be possible otherwise. Nowhere is this more apparent than it is in the School of Dentistry. The School of Dentistry at the University of Texas is the highest rated professional school in the entire University of Texas system. When U.S. News and World Report did its one and only rating of dental schools, this school was rated as the top school in the country. And in subsequent ratings, it's always in the top 5. Former officers in the military were essential to its creation. Military affiliation agreements began in 1982 with the development of an endodontics, prosthodontics, and periodontics program. And today, 60% of the periodontics faculty are retired military. And it still, as I said, ranks very highly in the national spectrum. So this astounding growth that's occurred in San Antonio's academic center in essence was catalyzed by the sure and certain relationship with military medicine. Now, just 55 years ago or so, this is what the campus of the University of Texas Health Science Center looked like. It was, there's a sign at the lower left of the slide that announces this is the site of the new medical school. But it was a dairy farm, and the 2 grain silos in the background were the dominant features of this part of San Antonio. Today, the Health Science Center is basically spread out on 2 large campuses on hundreds of acres of land, and it is the hub of San Antonio's almost $31 billion bioscience healthcare enterprise. Saying it differently, there would be no $31 billion industry like this in San Antonio were it not for the Health Science Center. If you follow what I'm saying, that would not have happened with the kind of growth that it's had without this association with military medicine. The slide on the left shows the new Academic Learning and Teaching Center on the Long campus, and the slide in the lower right shows the Greehey campus, which is comprised of several distinguished buildings. The one I can point out to you here that might be of some use in pointing out is this long gray building that dominates the lower right-hand part of the slide, is the 1,000-foot-long new research building, which in length equals the Eiffel Tower in height, and creates these research neighborhoods. It's a 200,000 square foot building for research we opened just a couple of years ago. The cancer center is right above that, and our clinical operations are right across the street. Several highlights about the Health Science Center that might be of interest to you. Now 3,200 students aggregated in 5 schools, about 6,000 people in the workforce, 1,000 trainees, interns, residents, and fellows. 1 of 6 individuals employed in San Antonio work in healthcare, and it's estimated by actuarial consultants that the Health Science Center is responsible for somewhere between 16,000 and 20,000 additional jobs in San Antonio. Our practice is called UT Medicine, consists of 700 to 800 subspecialists and specialists working all across the city, predominantly in our brand new outpatient building. And we have well over 1.2 million visitors or patients annually. I'm going to hit this again, and I think this is an aerial view with some happy music that shows, this is the long campus with several of our buildings. The new building that's the blue building at the top there is the new trauma tower at University Health System, and a new acquisition, a new inclusion in our portfolio, I should say. And then you can sort of see this from the backside. It's all in Northwest San Antonio. It's a tremendous place to visit, and it turns out that those who wanted the Health Science Center to be created there were clairvoyant. It was the right place to build it. It gives us room to grow, a 900-acre campus. It's been wonderful to see this growth occur. Today, San Antonio is known as Military City, USA, and you could make a case for it being known as Medical City, USA. A recent renovation at the San Antonio Military Medical Center was a dazzling recreation and consolidation of services and totaled $2.5 billion in cost. There are 150,000 enrolled patients in the San Antonio Military Medical System, and there are 100,000 additional beneficiaries who seek care there and other places throughout the city. It's estimated that there's somewhere between 90 and 120,000 VA beneficiaries in San Antonio. You add all this up, and you can see how this bond has been created. I want to say a word about trauma. It's a focus of ours and a focus of the military, and this city is completely unique in its trauma system, because the trauma system splits level 1 trauma between the San Antonio Military Medical Center and the University Hospital. About 60% of trauma goes to University Hospital, and about 40% goes to the San Antonio Military Medical Center. And the coordination that occurs between these two places could not occur were it not for the fact that this is truly a collaborative and trusting relationship. You could not create this citywide kind of divide in trauma and have it work seamlessly to the benefit of our citizens were it not for this relationship. I'm very proud of this. I'm very proud of those who have established it, to Ronnie Stewart and his colleagues at University Health System. He's the chair of the Department of Surgery. And trauma care in this city is first rate, and it is excellent and superb in both of these places. Kudos to them. Our educational collaboration is developed, as you might expect. We have student rotations, departmental grand rounds, residencies, and fellowships, which we share. There are 64 active duty military student scholarships, 234 veteran students funded by the Hazelwood Act, 37 military medical residents, 431 medical resident rotations, and we have Army paramedic training for 125 students annually. UT Medicine's clinical practice is dedicated to the quality of care of military beneficiaries. Some of that 100,000 people who are eligible for care in San Antonio, former military, do seek care at our facilities, and we're delighted to have them. We have complete staffing of the VA facility here. We have almost $9 million of annual research at the VA, and that's all taken care of or all developed by faculty at the Health Science Center. We have new University of Texas system-wide clinical trials network, which we think will be a benefit to the military research effort, and we are actively seeking ways to partner with the Department of Defense for that. A couple of highlights, and then I'll close. The largest single grant obtained by the Health Science Center in its 50 years of history is something called Strong Star CAP. Consortium to defeat PTSD is the newest iteration of this grant. It is led in distinguished service by Alan Peterson, who's a retired lieutenant colonel in the Air Force, professor-in-chief, Division of Behavioral Medicine in the Department of Psychiatry. And the goal simply is to reduce the prevalence, find new therapies which are effective for this disorder of PTSD. Something like 15% of returning military veterans are afflicted with this disorder to some degree or another. But as always the case, war and conflict shed insight on what happens in civilian life. And it's estimated that 6 to 7% of civilians are also touched by this disorder. So it is a huge problem, and it is being addressed in this ably by Dr. Peterson and his colleagues in the military. Another thing to mention is that this REMTORM network, this Remote Trauma Outcomes Research Network, has many similarities to what has happened in theater in Iraq and Afghanistan. If you take San Antonio on the right-hand side of this slide as the hub for evacuating patients who've been badly injured from areas along the Rio Grande River, you can see that the destination distance from Eagle Pass and Uvalde to San Antonio is roughly equivalent from cities that are remote to Bagram Air Force Base in Iraq. So this has been a good training ground for testing means by which people who are hurt can be rapidly evacuated to San Antonio and then given first-rate care. One thing that I find illustrates the creative nature of research is this collaboration between Julio Palmaz and Dr. Richard Schatz. Palmaz was a radiologist here in the Health Science Center, still has a clinical appointment. And he was impressed as he was going along through his training by a procedure that some of you who are older may remember as the Grunzig procedure. It was a procedure in which a balloon was blown up inside of an atherosclerotic vessel, and the plaque was basically mashed against the side of the endothelium of the vessel. The problem was that although this established patency for the vessel in the short term, the cracked atherosclerotic plaque led to aggregation of clot, and sometimes the procedure failed. So Julio worked in his garage on different means to find a scaffold that would keep the vessel patent. And he worked in collaboration with Dr. Schatz, who had a background as a cardiologist and a biomedical engineer. And they created this device, which is shown in the right-hand slide, that is called the Palmaz-Schatz stent. And this is the scaffolding, stent, and this is the scaffolding that is used by hundreds of thousands of Americans in a month. These are the scaffolds that go inside coronary arteries, peripheral arteries, and prop vessels open. Now, as you know, the new metallurgy of the 21st century is to embed anticoagulant material in these metals and thereby further increase their efficiency and increase their longevity. So this is considered to be one of the 5 most important inventions of the 20th century. Happened here in San Antonio because of this collaboration between these 2 individuals. When I was here the other day, I went to the exhibit hall and saw a number of creative devices aimed at improving trauma care. Another one of these devices currently in development here is a handheld suction device that could help people in field clear airways when there is blood or vomitus in the airway. And this is being worked on by individuals here. And it's inspired by the kind of work that was on display in the exhibit hall the other day. This individual is a dentist, Ken Hargraves, one of America's most distinguished pain scientists. He's collaborated with the ISR over the years and developed clinical therapeutics to improve pain control. He's supported by the NIH and by the Department of Defense. And the idea is one that came out of a collaboration with the Army because of the intense pain that burn victims suffer, and the fact that it's prevalent in civilian life makes it a public health problem. Poor pain control in burn patients increases the risk for long-term adverse outcomes, and 50% of burn patients report inadequate pain management. So there's a need to develop an non-addictive remedy. Now, I know this is a science slide, but I can explain this to you. I'm confident that everybody in the room will understand what Dr. Hargraves' research has shown. These substances called OLAMs, which are oxidized linoleic acid derivatives, are a unique substance that's released from this burn tissue. He took burn tissue from these wounded warriors and discovered that this substance was in high abundance in this tissue, but not in normal tissue. And then he further discovered that these OLAMs then occupy a receptor called the capsaicin receptor. In lay language, the capsaicin receptor is the chili pepper receptor. So if you eat something spicy and your tongue burns, or if you forget to wash your hands after you've been, peeling chili peppers, and you put your finger in your eye, the chili pepper receptor is the thing that is the end result that makes the skin burn, make the tongue burn, make the throat burn. So Dr. Hargraves' research is on finding a way to reduce the release of these substances, since they're the mediators of the pain reaction, or to find a blocker that prevents these substances from occupying the receptor that leads to the pain. And if he does this, he will have found a non-narcotic, effective way to control pain that would be wonderful. It wouldn't have the same toxicities, for example, of non-steroidal drugs, which have profound liver and kidney toxicities. I mean, think of it. There are 11 million people in this country who suffer from chronic pain. There are 20 million people in the country who have chronic headaches. If this kind of research leads to something tangible in reducing pain, then this collaboration will prove beneficial way beyond what has been observed in burn patients. Last couple of comments. I'm very proud to have established the University of Texas Health Science Center and Military Health Institute. If somebody asks me what my job is, what do you do with your time? The key element of my job is finding excellent people to carry the mission forward. And in this regard, I have been blessed to have hired Byron Hepburn to be the inaugural director of our Military Health Institute. Byron is a physician, he's a family practitioner, he's a pilot, former pilot in the Air Force, general in the Air Force, and he has enhanced our collaborative efforts with the military. I knew we had a lot of positive forward momentum in our relationships with the military. But I also knew there were things that we could do that we had not done. And Byron Hepburn is the exact right person to lead us forward. He's done a brilliant job with this. He's created we have a external advisory board that advises our institute, and partnerships with the University of Pittsburgh, Hopkins, the Mayo Clinic, UT Southwestern, and others are vital to making sure that this institute stays on track. This is a gallery of some of our most distinguished individuals about whom I've been really speaking. Dan Dyer, who was at this meeting earlier, is a clinical professor in emergency surgery, and he's important in the military because he's responsible for reserve deployment of a force of reservists who go all over the world in service. Brian Eastrich is a professor in surgery. Nick Walsh, Navy SEAL graduate of the Air Force Academy, wounded warrior, Purple Heart recipient, as is Dr. Roger Weed in the dental school. Ian Thompson is director of our cancer center. He's recognized today as the #1 expert on prostate and other genitourinary cancers, particularly prostate cancer. He's led the big men's health study that has changed completely the way we treat prostate cancer in this country. And he's a graduate of the military academy and a retired colonel. Carlos Rosende is the director of our clinical practice. Carlos is a graduate of the Naval Academy. He's an ophthalmologist, former chair of ophthalmology. And I mentioned Alan Peterson before, our esteemed member of the Department of Psychiatry who leads the Strong Star CAP program. Bruce Adams is the chair of the Emergency Medicine Department, led the William Beaumont Hospital's emergency department, and was deployed in Somalia for the famous Black Hawk Down incident. Laura Alvarado directs our continuing education and nursing school. And our students are part of the military legacy. Jeff Mars is a U.S. Military Academy graduate. He's been deployed 3 times to Iraq, and he's expected to graduate from the School of Dentistry in 2018. Rudy Gomez is a physician's assistant Navy corpsman and has been deployed to Iraq. Just a couple of the stories of the literally dozens and dozens of stories in our school. So as we look to the future, a bright future, we hope, for both of us, we intend to do all we can to continue this relationship, this very positive relationship with the military. It has paid so many dividends for us and for them. We consider them our brothers in this mission. We have planned research and development, certainly in trauma, which we think is a focus that we need to continue to develop for the reasons I mentioned earlier. Pain, if we could make a breakthrough in pain, that would be a life-saving, life-altering, positive benefit for millions of individuals. Sleep disorders and PTSD, it turns out that not being able to sleep is a critical factor in PTSD, not being able to get rest. And we have a group that is focused on that in collaboration with Dr. Peterson. And finally, we're just in the process of establishing an Alzheimer's and Dementia center here. There are very few comprehensive centers. We started a fundraising effort for this 14 months ago, and as of yesterday, we had raised $42 million to establish this institute. I particularly think this is important when one looks at the conflation of trauma, of the fact that San Antonio is a target for retirees, and 1 in 9 of us over the age of 65 will develop Alzheimer's disease. I'm on the leading edge of these baby boomers, and I know that watching my friends and colleagues suffer from this, either personally or in their families, has touched me. It certainly touched my family in a personal way. I know all of you have had that relationship with people or know of people who are afflicted with this. The only way the disease will be licked is with longitudinal trials and comprehensive care centers, and we're devoted to this purpose. I might mention also that there's a polytrauma unit at the VA, one of only 5 places like this in the country here in San Antonio. And so the fact that we have investigators studying concussion, investigators studying healthy aging of the brain, a third of our research is in neuroscience. And the fact that we've established this Alzheimer's Center and hoping to open it in a couple of months means that we'll put all of these ingredients together for what we think will be a powerful step forward in the fight against these diseases. So, conclusion is that military medicine and the Health Science Center have a rich, distinguished history of which all of us are enormously proud. And that as long as I'm here and as long as my colleagues are here and as long as this relationship exists, and ensures that in the future we will do everything that we can to make certain that both institutions are always made stronger, always made more robust by this happy association. We're very lucky, and I am very lucky to have this association with the military. Thank you very much for your attention. I'll be glad to answer any questions you have. Admiral, should we take a few questions if there are any, or? I can't see anybody out there, so if you could just shout it out, that would be terrific.
Good morning. Is it on? Good morning. My name is John Sharp. I work for the VHA Office of Academic Affiliations, where our office oversees the 120,000 medical professionals we train every year in VA. The question I have is we've been trying to work on some training exchanges for our medical residents between DOD and VA facilities, but some of the legislative laws out there are preventing us from being able to do that because in VA, our trainees have to treat a certain number of VA patients, and I think the same thing is true for DOD. Is there any goals in the future to try to change the legislation so we're able to, the medical residents can work with DOD patients as well as VA patients?
I'm not aware exactly of what you're referring to. I know it's the truth, but I don't know exactly which laws you're referring to. If you'll just do me a favor and grab me when I come off the stage here, I'd like to talk to you about this offline. There are restrictions. One of the things you have to do if you engage in this work, there are restrictions between our systems. So that, for example, when our students go to SAMC to have their clerkships, there are restrictions on what kind of computer access they can have. So there are hurdles that have to be cleared before you can have this kind of robust relationship. And what you relate sounds like something that is similar to that, and what I'd like to do is find out more detail about it and then perhaps get in touch with the right person who can help, who's been down this road and who perhaps has addressed this problem before. And if anybody in the audience has any additional insight to offer, I'd be welcome for that insight. We have what's called a Dean's Committee VA relationship. And the Dean's Committee VA relationship means that there's a collaborative group comprised of the administration of the Veterans Hospital and the university, namely the dean of the faculty, who adjudicate issues of importance such that they get resolved in a timely way for the benefit of the veterans and the benefit of the learners. And I'm sorry I don't remember or I don't know in non-Dean's Committee hospitals what the stumbling blocks might be. But I'd be glad to talk to you afterwards and I'll try to help you.
Just wanted to say that, Paul, I don't mean to put you on the spot, but Dr. Paula Shireman is one of our eminent vascular surgeons who's credentialed to the VA. We could probably have that discussion offline. And also, I'm looking at Scott Jones, who's our dean of our SAWSHEC, San Antonio Uniformed Services Education Consortium, for the GME piece, of which we're collaborating in San Antonio. We have several programs that are actually integrated as far as GME. One is nephrology fellowship and psychiatry. But we can take that one offline to give you the granularity you need. Thank you.
Hi, Paula Shireman. We have a really robust relationship between SAMHS, San Antonio Military Health System, our VA, which is linked by a bridge through University Hospital to our medical school. And we have a lot of programs that are actually looking at mangled extremities. We have a VA-funded study called VAVIS, which is the VA Vascular Injury Study, that looks at the long-term outcomes of vascular extremity trauma from OIF, OEF, OND. And we were just funded through the DoD for MEDALS 2. And I know they've talked a lot in this conference about MEDALS, which was the Military Extremity Trauma Amputation Limb Salvage Study, with the outcome showing that our service members who received amputations actually did better than those who have limb salvage, which initiated the return to run programs that have been so successful at the CFI and the IDEO devices and all of the things that we've been talking about at this meeting. MEDALS 2 hopes to look at this first cohort from OIF, OEF, OND that didn't have the advantage of the very intense rehabilitation for limb salvage that the second cohort in the last half of these wars have, and hopefully to look at the outcomes of these programs as well as look at geospatial, the location of the veteran or the active service member in relation to military treatment facilities, VAs, and other high acuity care aspects to see if their processes of care are different. And we are open for business for many more studies, hoping to link the VA and the DoD Trauma Registry. There's so much we can do that can help, hopefully, with the next war so that we're ready and can maintain the knowledge that has been created in this conflict.
Dr. Henrich, thank you for a great presentation. And I've known since the first moment we met and talked how dedicated you are to the holistic care of patients through all of our organizations. You faced, and you really well described the barriers, the cultural, the legislative, and so on. Now here's my question. If you found a lamp, it's a faulty lamp, but it has one wish left. If you could do one thing, change a law or whatever you could in your imagination to make this association, to take it up to the next level, what would that be? Usually a questioner says, I don't mean to put you on the spot. Then they put you on the spot.
Well, you have put me on the spot. Well, if you asked 100 people that question, I'm sure that there would be at least 50 different answers. I think I'd mention two things that will reveal immediately my background bias that I hope you'll forgive me for. If I could rub that lamp and I could provide insight to leaders of our country, it would be that not funding biomedical research is incredibly short-sighted. The NIH budget has been $31 billion. That's a lot of money, but it hasn't changed in 10 years. And the biomedical inflation that is baked into a budget like that is 3 to 4% per year. So we've lost 15 to 20% of our research capability in this country. Leafing through the New England Journal of Medicine yesterday, and I was looking at the the latest trials using the New England Journal of Medicine as a surrogate for excellent research. Looking through that journal, of the 4 trials which were presented, 3 of them from overseas. America has the best system of studying science in the world. People still come here in droves to be near our scientists, our investigators, in the military and in our civilian institutions. And to not fund this is short-sighted. And that's one thing. But the real crime in this, the real tragedy in this, Admiral, is that the advances that could alleviate human suffering are thwarted by this lack of funding. I'm thinking about advances that have happened in the last few years where the science is powerful enough now to do so much good, but the resources are so difficult. Paula Shireman has an NIH grant. She sends in a new grant today. And she's a distinguished investigator. She sends in a new grant today. She has a 1 in 11 chance of having it funded. It's hard to get people, young people, to go into research when the field in which you're asking them to go into has that kind of a track record for funding. So I'd say that my answer to your question is, if I had one thing to do, I'd have everybody understand that research is good for Democrats and Republicans equally, and for independents, and for just everybody. Thank you again for having me here today. God bless you. Thank you. Okay.
Just want to present you a little token of our appreciation for you spending your time with us and hearing your words. Thank you again.
Thank you again. I appreciate it.
Okay, it's break time. It is a quarter of. We will start promptly at 0900 with our final plenary session, the panel discussion, The Journey of an Injury, which I hope you've all been looking forward to as much as I have. So 0900 back here. Thank you.